Okay, so it seems as though now we're officially underway. Again, I thought people had some great points, and we'll be discussing all of those issues further. I'd like to turn it over to Jessica now. She's going to give us a little bit of an overview, and as I said, speak a little bit about the eco map. So maybe in preparation, if you want to turn to that in the summary.
All right. So Adam is in his 20s, living on the east end of Long Island with his parents and older brother. His top character strengths include humor and honesty. Adam was initially referred to START due to an increase in behavioral health symptoms presenting as physical and verbal aggression characterized by throwing items, hitting his parents, yelling, and property destruction. And to assist his family with these changes, Adam had his referral discontinued several months before this referral, and this was seen as the primary reason for this increase in aggression. As you can see, starting at a young age, there's been worries in caring for Adam as he was inconsolable. I want to point out that as an infant, the neighbors had contacted 911 due to believing that Adam was being harmed after hearing screaming coming from the home when the parents were merely changing his diaper. It was hypothesized that perhaps given the extent of Adam's irritability from an early age, this may have led to the parents doing anything and everything possible to console him and keep the peace to prevent further contact with the police. This pattern may have contributed to the behavioral health symptoms he exhibited beginning at a very young age, which have continued. In addition, there seems to have been a divide between the parents in regards to their relationships with each other throughout Adam's life. The parents have had different opinions on the treatment options for Adam and what would be best for him and the family. Adam's father was interested in residential placement throughout Adam's life as well as presently, whereas his mother is not interested in having Adam move out and would like to have him continue living at home, and has expressed a sense of guilt with him living at a residential placement in the past. As seen throughout Adam's time in school and at the residential treatment center, he was the victim of bullying. It is interesting to point out that recently he reportedly engaged in bullying at his day program by labeling others. This could have been a result of Adam having been bullied in the past, since victims of bullying sometimes become the person doing the bullying. Adam can also be doing so in an attempt to be cool or show off to others. He definitely wants to fit in, but does not always have the skills necessary to form relationships. I'd like to draw your attention to the eco map. As you can see, there is a strained relationship between Adam and his father, while the relationship with his mother is very positive and strong. This further shows the divide between Adam and his parents. There's also a positive relationship between Adam and his brother. It should be noted that Adam's brother often lets Adam hang out with him and his friends. Adam enjoys spending time with his brother and his brother's friends, but has difficulty accepting that he cannot do everything his brother does. There may be an element of envy at play in relation to his brother, component Adam's unrealistic expectations of himself with respect to other relationships. Adam only recently started with his psychiatric nurse practitioner and the current day program provider, and they are still working on building a rapport with him. As an aside, Adam seems to be making a positive adjustment to his new day program. Adam was apprehensive about going to the day program at first due to his anxiety, perhaps out of concern about the possibility of being bullied or finding girlfriends. However, Adam actually reports that he has made some friends and is enjoying being part of a basketball team. Adam and his family recently completed in-home therapeutic coaching, and there has been improvements with uniting the family, particularly in terms of Adam being able to see his father in a new light, recently calling him funny and sharing that the father can always make him laugh, whereas in the past, most of what Adam said about his father was negative and showed a distrust in him. During Adam's early childhood, it was noted that he hears voices, but when exploring this further with Adam and his family, he shared that he has never heard voices. Instead, Adam described that when he is anxious, his own thoughts play over and over in his head, as in a tape playing over and over, or like a hamster going round and round on a wheel. As a result, there is a question as to whether Adam actually has experienced symptoms of psychosis and whether the schizoaffective diagnosis is accurate. Indeed, he has had several different diagnoses and medication regimens over the years, suggesting that there has not been a consensus as to the nature of his behavioral health symptoms.
Or maybe just the beginning.
Yeah.
So, does anybody have any questions at this point before we continue? we'll see, we'll talk a little bit about how coaching has helped with this case. And maybe we're starting to kind of figure out some of the pieces and to understand it a little bit differently since there hasn't been consensus all these years. There we go. So in terms of the reason for referral, the actual and so, there's a little bit of a problem with that. There's a real negative connotation. First kind of, suggests that the individual is bad, and that's what the problem is, and that they need to correct their behavior. Intentional or volitional under the person's control when in fact that may not be. And it kind of sets the tone for everything. So we're going to progress through the slide presentation. In addition, a little more specifically, the initial referral also indicated, and of course at the time of intake, that there was an increase in aggression. As Jessica mentioned, the medication had been discontinued, so perhaps that caused that. He was pushing others, punching and hitting, grabbing people. There was an increase in property destruction, in addition to threatening others. And they also saw an increase in his mental health symptoms, which included both depression and anxiety.
Yes, that's me. In ASD and IDD population, aggression by far the number one reason people get to me. Not even close. Most common reason for referral. And I see that here when I get referrals from coordinators. So as I was doing this slide, I was just curious. In SIRS data, is that the number one reason people come to START?
Yeah.
Yeah. What kind of get a guess a number? Where do you think it's at?
92%.
Right. So it's pretty crazy how high it is. So and on the first bullet point, I wrote that it's a fairly worthless reason. That sounds like kind of a provocative word to use, but it's not meant to undermine the importance of aggression for anybody who's taking care of these people, caretakers, family, wherever they're residing. But the point being that you can't take the word aggression at face value. There's so many things that could cause it. And if I do as the physician, what's my recourse? I can start sedating the individual with anxiolytics, anti-seizure medications, everybody's favorite antipsychotics. And it may turn out to be the right intervention, or it just might be that I'm using a shotgun to sedate somebody that's coming to me for a lot of different reasons. So if you're going to look at an aggressive individual coming to you, my job is obviously to point out the medical, and it's pretty straightforward. The person could be having pain anywhere. It's really, you need to do a review of the system from head to toe. Are they having toothaches? Are they having reflux? Are they having constipation? Endless choices. Extremely important to get a good medical history and see if there are any signs pointing towards a medical problem that is resulting in the aggression. Also have to mention, I get referrals for family, from family and caretakers who are smart, and they have ruled out all the medical stuff. But that's when they cease being smart, and we start to hear about the wrongful actions. To say it's just been behavioral is also very simplistic. There may be other mental health reasons that they're coming to aggression. Maybe they're very anxious, the individual, maybe they're very scared and they lash out as a way to protect themselves. Someone that's been bullied, as in this case, maybe has a heightened sense of feeling threatened. I've worked with soldiers who have been shot at, and they'll come back and tell me how quickly they jump into fight mode. And it's just this massive adrenaline rush at the wrong time. And they can't really stop because their anxiety and fear is so overwhelming. And even psychosis. We're talking about in this case, it may not be psychosis, but in some cases, there may be psychosis causing the agitation. Are they hallucinating? Are they feeling or experiencing something that's threatening them? Are they bipolar, going through a manic episode? And aggression is simply a manifestation of the cyclic mood disorder. So the summary on this is that aggression is real. It can be dangerous and it needs to be treated. just not to take it on face value and pick it apart and try to figure out what's the various variables that can lead to aggression as the presenting symptom.
And similarly, the focus on behaviors, which in the field of IDD, often, if the focus is on the individual's quote behaviors and how to eliminate those, but that may be equally non-specific. We all have behavior, good and bad, and when we focus on the behavior, the role of environmental factors is emphasized to the exclusion of more of the innate or the inherited or the biological factors, as Dr. Kent said. And we are going to be speaking a lot more about that because often it is the biological factors. I know you mentioned how many people come in and they have examined that, but more often than not, they haven't considered the biological, and that is the piece that's overlooked. Even when the function of the behavior is examined, still it generally only considers what's observable or measurable when there may be quote unquote unseen aspects. Which often it's those unseen aspects that explain why the same person, the two different people in a very similar situation react very different to that same situation because it's what they bring innately. And finally, interventions aimed at eliminating behaviors may be less effective if we don't identify the underlying vulnerabilities, if those haven't been considered and addressed. And so that leads us to an alternative to, kind of looking at things at face value. And it's the biopsychosocial model, which is an interdisciplinary model that looks at the interconnection between biology, psychology, and socio-environmental factors. And the model specifically examines how these aspects play a role in topics that range from health and disease models to human development. And the model was developed in 1977 by George Engel, and it was the first of its kind to employ this type of multifaceted thinking. And the model was developed, at least in part, in response to the limitations of diagnosis. So in turn, just as we spoke about the limitations of speaking about behaviors and aggression, diagnosis also has limitations because different diagnoses don't necessarily have discrete boundaries. A good example is anxiety and depression, and Adam, as we'll see and speak more about, has anxiety and depression, and often those are intertwined, and it's kind of like the chicken and the egg. You're not quite sure, which came first. Likewise, in terms of diagnosis, there also are in different areas of the brain where, well, this is anxiety, this is depression. So it's not so discrete and clear cut. And two people that have the same diagnosis actually can present very differently. Diagnosis doesn't necessarily clear things up either. So by focusing on the biological, the social, the psychological, and putting those together, the idea that it's a more comprehensive conceptualization of the individual and understanding this particular person. It's important to notice in the model that in addition to just biological, psychological, and social factors and the independent roles that they exhibit, that there's also an interconnection. So there are areas of overlap. So you see, for example, the overlap between biological and psychological is temperament or personality, and that's that age-old nature versus nurture that maybe it is about 50-50. In addition, things like family relationships and trauma, that's an interconnection there between psychological. Trauma it's traumatizing certainly, but sometimes it depends on, early life experience. And if there's been adversity, you may be more susceptible and maybe less resilient to the impact of trauma. So again, that's the, interface between social and psychological. And then with one example between social and biological are drug effects, where certainly the situation can even heighten a reaction to a drug. It's not enough to just identify the factors in each area, but again, to recognize those interconnections and kind of fit those puzzle pieces together. And it's by doing that that it really offers the richest, most comprehensive understanding of the person. And it's kind of like, and I guess most of you know, it's kind of like here at START, we're like detectives where we're always seeking to understand what's going on beneath the surface and fitting the pieces together. And I think Adam is a really good case to kind of take a look at that with, because again, on the surface, it was about he was aggressive. I think he even threw a basketball at Mike, and that was his, presentation. And as we kind of put on our detective caps and look, there's a lot more going on, as we'll see. So why don't we take a look at that? And so here's a biopsychosocial case conceptualization for Adam. And you can see that it's a lot more complex than just aggression, and it has very little to do with controlling wrongful behavior. In a moment, Dr. Kent's going to say a few words about some of the biological factors, but first, I want to point out, for the sake of simplifying this diagram, the overlap or the interconnection. We haven't included those areas of overlap, but the way we've addressed it here is that we've listed, for example, anxiety, ADHD. You can see that they're under biological, but they're also under psychological. So, certain things like that really have two factors that come from two, the biological and the psychological, those interactions. So Dr. Kent, maybe you can start us off with talking a little bit about the biological.
Yeah, sure. So in this biopsychosocial model, biological factors are important. So in this case, just going to do an overview of some and then get into the more detail. In utero exposure has been known for a very long time to be a very significant variable. People have heard of the old thalidomide cases? Everybody aware of those? Yeah. That had the structural abnormalities, shortened limbs. That was obviously very devastating, but very obvious. A lot of medications are not that obvious. There could be structural or developmental deficits, but not always so clear. They may be more subtle in the impact that it has on the development. But it may have played a role and needs to be considered. So butylene, which I'll get into on a later slide, it's used in pregnancy. A little controversial. What it does is it delays the uterine contraction, so you hold the baby longer, you don't have a premature delivery. And many gynecologists approve of it. Some centers don't. So there's a little bit of back and forth about what should be allowed, but it can have an effect. Autism on the list, because autism has structural deficits, developmental deficits. Modern science isn't 100% sure exactly where things are, but there certainly seems to be some cerebellar involvement. But I think that's another important thing to look at, obviously, when assessing an individual as they develop. Epilepsy, clearly hugely impactful. Seizures themselves can have behavior, right? They could be a behavioral seizure. It doesn't have to be a loss of consciousness. But post-seizure functioning can change behavior, right? Post-ictal, that kind of thing. Medications to treat seizures can impact behavior. So again, multi-layers, multi-variables that contribute. I'm going to get into the MTHFR gene. That also shows how genetics and nutrition interface, with the result being behavioral and psychological, psychiatric type of symptoms. Bullying sounds environmental, but again, it goes in this column because there are biological outcomes of bullying. There is no doubt about it. There's enough studies now that show an individual who's been bullied, especially at certain times in their age, will have biochemical and biostructural changes in their life. And there's some recent ones with cyberbullying. They're just unbelievably phenomenal studies that just show the impact on people's brains, which is sad, but so that's on the biological list as well.
And so with respect to some of the psychological factors, as we already spoke about, Adam was inconsolable as an infant. And in a moment, I'm going to talk about how that really is kind of multi-determined, and you already can see the complex web that kind of comes into effect with some of these. Early on, he was diagnosed with PDD, when that was still a diagnosis, and of course now autism. he's always had anxiety and depression throughout his life. And in fact, most recently, the anxiety has been, focused on relationships. There wasn't a clear transition plan under the social factors, so there's been a lot of anxiety about the future. He asks a lot of questions about that. There's ADHD, and of course, the mild ID and executive functioning deficits that kind of come with that. There's a mood disorder. For a while, he was diagnosed with the psychosis, NOS, and a mood disorder, which now has been switched to the schizoaffective disorder. As we already mentioned, we're kind of questioning whether there really is psychosis or if it isn't better explained by the autism and then perhaps an anxiety and mood disorder. And Jessica is working with the new psychiatric prescriber around that. The residential placement, certainly that had an impact. There was separation early on because of that. And it really, as we'll speak about, that kind of impacts even with interacts with the social, because the mother in particular had a lot of guilt around that. And then of course the history of bullying, which I'll speak about, not just bullying in general, but also why the autism for Adam, more so, kind of resulted in that bullying, or could have caused some of that bullying. And in terms of social factors, to begin with, he has that difficulty establishing and maintaining relationships, which you can see how that, may affect the bullying. The mother's guilt, that triangulation with the father, where he doesn't have the best relationship with him, but the mother's always been his protector and over-concerned. We'll speak a little bit about why that may have developed. The sexual development and boundaries, there has been some sexualized behavior. The trauma stemming from both the separation from the family as well as being a victim of the bullying. He does, as Jessica spoke about, have a decent relationship with his brother, which may not always be the case in a situation like this, but the brother willingly takes him along, goes out, includes him with his friends. But, Adam is aware that he can't do everything his brother can, and so it does cause some problems. And as I already mentioned, the transition plan after school. Before we move on from this slide, I just wanted to speak a little bit about how some of these factors may be multi-determined. So, for example, the fact that Adam was inconsolable as an infant, if you think about it, often infants with autism, that's one of the early signs that as infants, those babies generally are very difficult to soothe. So Adam, came with that wiring, but then in addition, having been exposed to the terbutaline in utero, that also results, and we'll speak more about it, but results in infants that are more fussy. So that may get added to that. And then, Jessica spoke about that example of when the parents were changing his diaper and the neighbors were so concerned that he was being abused that they called the police, that, maybe some sensory sensitivities in terms of the diaper change too. So with all of those factors interacting, really to contribute to that fact that he was inconsolable and his temperament that way. Same for the sexualized behavior with autism. Sometimes you see that focus, that hyper focus sexually. But in addition, the mother, right from the beginning, was so concerned about soothing him, taking care of him. Perhaps she had her own guilt, and we'll speak more about that. That maybe she overstepped some boundaries and took charge of things, and she was helping with his toileting when he was as old as 10 years, when really he didn't require that adaptively, but yet there she was, and maybe crossing over that boundary at a time when puberty was coming. And so again, I'm kind of offering these just as just a couple of examples of what an intricate web it is, that you see how many factors intertwine. And the same for the bullying. With the autism and the intellectual disability, you see executive functioning deficits, which they can lead to emotional dysregulation. Then that increases the risk of exposure to being a victim of bullying. And then that leads to more emotional dysregulation. And then that may account for, some of those adverse outcomes. So we kind of highlighted some things here in terms of understanding Adam, and now we're going to speak a little bit more and highlight some of the specific factors. So.
I started this slide by Googling women in labor and then realized I'd end up on a fetish site. So tell me, I'll notice what's all we looked up on our Surface Pro site. This was for the slide, so. Anyway, that being said, terbutaline, as I mentioned before, is used to stop preterm labor. Anybody know what it's used for in other medical reasons? Terbutaline, everybody heard of it? It's respiratory. It's in a lot of the inhalers. It relaxes the bronchioles. So if you have asthma, bronchiolitis, that kind of thing. But the risk of preterm labor is very huge, so it's not a simple decision whether or not to use it. If a child is born before 37 weeks of gestation, there's a huge risk of neurobehavioral deficits. So again, how useful is terbutaline? I'm not a gynecologist. I sort of went through the research. Looks like it definitely plays a role. Again, some places use it, some don't, but it's definitely there. The problem is when you look at where some structural deficits may be from, it's used in maybe cerebellar area, and again, that's associated with a similar area where you see autistic disorder. And what Denise was mentioning, the irritable infant, that's very, very common. The first couple of days of life, and then extending a little further, there seems to be a large amount of irritability from its use. A lot of animal research on it. It's always hard to extrapolate animal research to human research, but one thing that is clear is exposure during the third trimester, which makes sense where you're going to use it the most. It was almost a 4-fold increase in autism. So that's interesting. When it's used extensively over there, that's where you see it. So the critical periods of development in a fetus are crucial here. There are times where the nervous system is more prone to having negative impacts by a foreign substance. They found in animal studies the impact was on serotonin receptors. There was what's called synaptic hyperactivity and upregulation of the receptors. And again, this could be a whole lecture in itself, but the point of mentioning is that the brain biochemistry, these changes are clearly associated with neurobehavioral difficulties, future diagnosis of psychiatric conditions. So it seems likely there is a risk of using it for this type of therapy. And how it does work is it relaxes the uterine muscles, prevents the spasm, prevents the early, movement of the fetus towards delivery. So bottom line, I'm looking at terbutaline as a factor, extended exposure in a male fetus, administration during the critical time of the fetal development are all where the greatest risks lie. So again, life's multivariable. In any given case, it's hard to say if a child went through this, what's the percentage? Because the family could say, the system could say, okay, so we had this, what does it matter? Well, we don't know, but it does help to explain it a little bit and not just think it's wrongful behavior, that there may be something biochemically happened that set the stage for this to start. And I know somebody brought up about, that connection between the child and the parent, bonding, vice versa. Well, if you have a kid that is extremely irritable and difficult from hour one, it's going to complicate that and make it harder.
And certainly we're going to talk a little bit more about that on this slide. Interestingly, there was one study where, as you see, elevated stress levels in the pregnant mother are associated with that increased risk of the fetus developing autism and epilepsy. And in this one study, it was only when combined with the elevated stress in the mother. Again, reflecting that interconnection between the social, psychological, and the biological. And in the case of Adam, we have to remember that not only was there, the preterm labor and being given the terbutaline and then having perhaps that anxiety on how that might impact her unborn child, but she also was diagnosed with breast cancer during the pregnancy. And so that likely there was a lot of anxiety about that, and especially since she wasn't going to undergo the treatment until after the baby was born. So certainly there was that stress. And as Dr. Kent spoke about, during the neonatal period, infants do show heightened reactivity to stimuli. They're more jittery, they're more fussy. And we spoke about how for Adam, it's important to note that with the autism, that he already, had that proclivity where perhaps he was going to be inconsolable. And I think you spoke, Mona, a little bit about that attachment and how that might affect the mother-child interaction. And, certainly it does. It undermines the mother's confidence in being able to soothe her child. Early on, new mothers focus on anticipating when the newborn will be hungry, how much stimulation they can tolerate, how much effort it takes to console him or her. And so the mother's working on that and really successfully navigating that developmental task lays that positive foundation for the infant-mother attachment. And the infant's capability for effective monitoring is what allows him or her to interpret an experience according to whether it's pleasurable and to use actions, crying, whatever they can, to guide the mother's response. And it's that response from the mother then that if it successfully meets the infant's need, forms the basis for trust. And so you can see that if you have an infant who's inconsolable, both of those is the tasks, building that confidence in the mother and the trust in the infant are going to be impacted. One study compared medicated with terbutaline in utero versus non-medicated mothers. And some of the findings were that although the behavioral differences between the groups did tend to disappear, the mothers in the medicated groups tended to view their infants as more difficult than did the mothers who had received no medication. And infants in the terbutaline group were not able to inhibit their responses to noxious stimuli as quickly as infants in the control group. And their internal stability was more disrupted by stimuli. So they were more stressed and showed more stress, in response to things in the environment. And infants exposed to terbutaline generally were able to improve their behavioral organization in the neonatal period. And their recovery was comparable to the recovery of infants in the control group. So, in other words, that pretty early on, those infants that are exposed to terbutaline do recover, and it kind of evens out to those that haven't been exposed. However, with some of the other factors for Adam, given the fact that he also had the autism, and then the mother and the fact she was battling the breast cancer, perhaps that got extended. And we do hypothesize that this formed kind of that basis for perhaps the attachment being disrupted, where now the mother did show an excess perhaps of concern and trying to soothe him. And it kind of set up that dynamic in the family where the mother was going through painful efforts to try to keep the peace for him and console him and soothe him. And, whereas the father didn't come from it from quite that same place, not maybe having that same guilt since he wasn't administered, he didn't carry the child. So we do believe it formed the basis for that triangulation, which continues to today. And that's a really important point, really something important to look at, because otherwise, if we just saw that pattern and we didn't understand what the basis, then we go about it and we're less effective. And we'll talk a little bit more about that later on. In terms of some of the other impacts, you do see possible motor developmental delays, which indeed Adam has, cognitive dysfunction, so a weakness in attention skills, the psychiatric diagnoses of autism, ADHD, and cognitive disorder, NOS. And there was a study, they looked at 2 adolescents that were exposed to terbutaline in utero. And what they found was that there were varied neurodevelopmental profiles when they underwent neuropsychological evaluations. So they looked very different. In one case, the person had an average, overall average intellectual functioning, and in the other case, it was borderline. So they do believe that the average intellectual functioning kind of was a protective factor, and that was why the profiles look so different. But the bottom line that they concluded was that there's definitely some cognitive dysfunction, but it really varies in degree, and there's no way of predicting that. And then, of course, we already spoke a little bit about when we were speaking about the mother-infant interactions, but the possible guilt of the mother, and particularly in this case, just knowing that not only did she have the tuberculin and feeling badly about that, but also the fact that she had to undergo the biopsy and, knew she had that stress of the breast cancer, in the case of Adam. So that sort of set the tone. And indeed, she has, as Jessica's worked with her and Patty and doing coaching, I know the mother has verbalized that she did feel guilty.
All right, I'm getting to another medical issue. First of all, everybody know the difference? Folate and folic acid or no?
One is natural.
Yep.
One is necessary for pregnancy.
No, well, they're both necessary, which would be the next slide. That's the actual answers. They were kind of the same thing. One's natural, one's, Barney chewable. Not quite so natural.
Oh, yeah.
The next slide. So they're both water-soluble B9 vitamins essential for the nervous system and for many, many functions in the human body. Word folate, foliage, Latin, leaf, so that's where we know it comes from. It's clearly much healthier, as I said, to try to eat the natural stuff than the Wilma or the Barney ones. It's those taste a lot better. And if folic acid or folate is too low in your diet, it could have very significant consequences also in a pregnant woman. The synthetic part that you're talking about is added to flour. So you see it in cereals and flours and breads. That's to just make sure that people get it. Folate needs to be converted to L-methylfolate in the body in order to be effective. And this is very significant because on the next slide, we're going to talk about an enzyme that is deficient in a lot of people, and that was being tested in this individual. And if it's not functioning properly, you won't make that conversion. This is a little immature also, but how do you make somebody not feel bad about being a mutant? All right, there you go. I had too many question jokes. I don't want to. That triggers me. So MTHFR, that stands for methylene tetrahydrofolate reductase, and it's getting a lot of attention in the lay press with a genetic mutation that may lead to increased homocysteine in the blood and therefore low levels of proper folate in the body. The test is done by a swab of the cheek, genetic testing, and it can show if the individual has the mutation. Now there's homozygous and heterozygous. You get one from each parent. Heterozygous means one is off, homozygous means they're both off. So theoretically, if they're both off, that's when you're screwed. You're not going to be making any of the proper tetrahydrofolate reductase. In theory, I'll get to that in a second. So quite some time there are articles about having to put everyone on supplements of L-methylfolate, and they may still have significant enzyme activity. In fact, that they are homozygous. That's the interesting point. One of my kids is homozygous, and we affectionately call her our mutant, and she's fine with it. She's also redheaded, so she's just the ginger mutant. But anyway, she went for the more advanced study, and they told her she had about a 10 to 14% rate of it functioning anyway, even as homozygous. So the point being said, it's definitely worth testing because it's reduced drastically and it's easy to treat. But homozygous doesn't mean it's a total wipeout. So you want to know if it's a heterozygous or homozygous. And again, it's easy to treat. Once you get the blood test for homocysteine, that'll show you a little bit more how serious the whole thing is. So what we'll do, you have the individual take the L-methylfolate instead of folic acid, because again, you could take a boatload of folic acid, but it's not getting converted to the compound that you need. So it's not going to be helpful. And you may or may not have heard of something called Deflin. Deflin is the one, it's called the medical food that the FDA approved that is L-methylfolate. And the fascinating thing about Deplin, it was approved for, not this, it was approved as an add-on for depression. When people are not doing as well on antidepressants, throw them a little Deplin and they get a little happier. That's awesome. So you wonder, if you go, I didn't think that was fun, okay. If you go back and you review all those people, do you wonder, maybe some of those people had this and we didn't know, and we were inadvertently treating this and just thinking that it was helping their antidepressants, so it's a little bit hard to know. But again, a lot of people never tested. The L-methylfolate helps, but definitely worth testing the MTHFR gene, getting the homocysteine checked. And if it's at all borderline, there's not a lot of downside. There's really no side effects to the medical food supplement. But when it is an issue, if they really have minimal activity of this gene, not only is folic acid not helpful, it's actually dangerous because it builds up in the liver and you could have liver damage. And these individuals actually have to watch their intake of leafy vegetables. So these are the only kids that can say to their parents, I'm not allowed vegetables, give me some potatoes and give me some meat. Because they can't process it. So it's something that we have to keep an eye on.
Who typically gets tested for this?
It's interesting. It's not, I don't know that there's a pool that we know of. The problem is a lot of doctors don't know about it. I've tested people randomly by just getting their testing for psychopharmacologic intervention. And there's a little box on the gene side, I think, do you want this as well? So I figured it can't hurt. If I'm going to think about using Deplin, I don't know medically what would drive a private care physician, an internist to get this, unless they had other signs of, which I'll get into, homocystinuria, which may bring up some changes that they have to do. But yeah.
So just for clarification, as I'm not very familiar with this, so you're saying that this gene mutation can occur in an infant,
It's in an individual, sure.
in any individual, due to if the mother and father are lacking in the same.
Correct.
Okay, so, okay, never mind.
But you wouldn't know.
Right.
Right.
But yeah, because I'm just thinking, I have to think it through.
Well, my next slide may help, because the next one is a little bit about homocystinuria, which
You're saying you
increases.
wouldn't know, so there's no way to prevent that from occurring. You can't test that in the mother and father during.
You could, it probably wouldn't be cost effective because the bulk of people, even if they have the heterozygous, they're going to be okay anyway. It's when it's homozygous, you have a bigger risk and it's a smaller percentage. Not a bad thing to know, but it's not, like testing with certain genetic diseases that are deadly, and it's just going to be routinely done.
Okay, and the result of this mutation on an individual, what happens as a result of the mutation, like outside of metabolism medications? Is there any other thing?
I'll speak a little bit more.
Okay.
I don't know if your question is how it affects them
Yeah.
psychosocially, or I'm going to speak a
Sure,
little bit
yeah.
about that.
The medical result, which I'm doing, it's a reduction in the presence or the efficacy of that particular enzyme. And then again, it may mean nothing. It may mean a little something, but it's worth evaluating and seeing, if you have some concerns. But
Sorry, I'm
the
trying
next
to
slide.
understand what I'm asking. I feel like I have a lot of questions because I've never heard about this before.
Yeah, it's getting more press, for good or for bad. I think it's good that it should be looked at because it can be pertinent, but now sometimes it's getting overlooked at in the sense of, oh, we have that explains everything. And probably not. It's just probably a factor.
And I don't know if you're going to speak about it, but it is just because it's getting more press. It's also getting more press where it seems to often occur in individuals with autism. So they're starting to look at that. And I just think as we understand all these disorders more, genetically and what's going on, we'll see that it may be that at a certain point in development, that may be something that kind of results in the autism also, is responsible for this.
It's interesting. I have an individual that is assigned to my caseload right now that has a genetic mutation that was caught on a gene site test. He has autism, and the doctor is saying a lot of medications don't work because of this. I don't know if that would be something separate or would sound like this could be the cause.
No, this wouldn't be the cause of the meds not working at all. I think it would be just a finding that's also listed on
Okay.
there. the meds not working would be because they had a complicated pharmacodynamic breakdown of that substance.
Okay.
But yeah, this is just on the list.
I think I had read something about metabolizing medications in here.
Yeah.
That was just out there. Thank you.
I mean, coincidentally, we sent my daughter for one and found out that we're Ukrainian. I don't think it has anything to do with how we break down medications. Or our political preferences, but it just incidentally on gene type findings. So,
Okay.
yeah.
And it does say that about the way he metabolizes the
Oh, okay.
medication, but that was just another fun
Yeah.
when they conduct the gene
Thank
type
you.
testing. You know,
Got
they find out that he doesn't metabolize medications, but they also found that he has this
Sure.
genetic mutation.
Okay, thank you.
Are you ready for the next one?
Yes. And this may show you some of the stuff that may alert people to it. Homocystinuria means there's a buildup of homocysteine because when that enzyme's not working, it's not processed properly. So what happens if you don't have enough of the proper B9 in your system and the gene's not working well? In a young developing child, you can see eye issues. That's real important, especially in the lens of the eye. Nearsightedness is very, very common. Bone weakness, blood clots, chest deformities, and which I'll have these two more of also neurodevelopmental possibilities. In an adult, you see an increase in depressed mood and anxiety, mood changes being the more frequently reported, pale skin, weakness, paresthesias, which is a little bit of tingling in the fingertips. And a lot of these, as you can see, are non-specific, and it could be mistaken for fibromyalgia, it could be mistaken for some autoimmune disorders. That's why when you have somebody in the autistic population having some of these non-specific things, getting the genetic testing and looking for genetic abnormalities is probably a good idea to see, and we could rule out the MTHFR mutation.
So with respect to some of the psychosocial aspects, first off, I want to point out that Adam has the MTHFR gene mutation and that only was discovered recently. So the deficiency existed all along. As we said, a genetic mutation is present at birth. So even though it existed, we didn't know it was happening, but yet it was having these impacts. And so generally what you see is anxiety. So sometimes that presents as aggression, difficulties with impulse control. Certainly that's what we saw in terms of, Adam's reason for referral. There's also depression with irritability, again, very characteristic of Adam. And so you can just see that if you focus on the behavioral manifestations and just what you see here, in this case, his aggression, that often these kind of unseen internal kind of attributes are overlooked as possible factors in contributing to, how he's conceptualized. In addition, and I think Dr. Kent touched on this, but there can be physical pain and discomfort as a result of this. And of course, whenever somebody's dealing with that, that affects their functioning. So if you're not feeling good, it can affect you just cognitively, you're off, your communication, socially in your relationships, or even just your daily living skills. And we will see, and there probably are many reasons for it, but when Adam ended up back at Abosi's after he was in the residential treatment center, in his IEP, they spoke about that one of the reasons for counseling in school was his somatization, so that often he would complain about a lot of physical kind of things going on. And so perhaps, it was a result of this, or sometimes, as we'll see with bullying, individuals may somaticize symptoms too, where they end up with complaining about headaches, gastrointestinal distress. And I think at the beginning with the intake, that was an issue for him. Right? He did have a lot of gastrointestinal distress.
Okay. This is just to introduce the topic, obviously, of bullying, and can be defined in many ways, especially with the advent of social media, and the cost is immense on all different levels. So let's push to the next one. All right, now, obviously bullying, as I think this room, people don't really need to hear it, but it's devastating. The association with anxiety, depression, PTSD. So it's not surprising to find out as a physician that long-term changes to the brain may be behind a lot of what we see behaviorally. Bullying alters the stress hormones of the brain, and that may be one of the ways we see long-term changes. Chronic stress in humans is a known risk factor for drug abuse. The theory is that if too much of the stress hormone remains in areas of the brain that are where rewards are processed, the organism is going to crave substances that work in that area because it's so depleted and so depressed. So they did studies in rodents where a juvenile animal was placed in a cage with a dominant and abusive older animal. And the alpha rodent kind of bit and pushed the other one. I'm making a face, it says. But I guess,
No, rats are nice, they're really smart.
yeah.
But they are, they're so smart.
At least this is for medical reasons, and not to come up with an incorrect stuff.
It doesn't make me feel any better though.
Yeah.
No, sorry.
Right, well, it makes you feel better. They gave them cocaine. And they did a comparison. And the ones that were bullied went through the drug at a much higher rate than the average rodents.
Oh, it's really sad.
All right, well, they were briefly very happy rodents. And they lost weight, so they were trim and fit and happy rodents. But here's the scary part. The bullying didn't really have to go on for a very long time. In fact, they narrowed it down to 5-minute episodes, only 3 or 4 times ever. That's it. And then these rodents had these changes in terms of their chemistry of their brain and their craving substances. Now, if you doubt the importance of rodent studies, there are studies in humans, obviously, they're not going to be similar, but there are some. And what they found was in bullied children, abnormal levels of cortisol compared to that of non-bullied peers. This seemed to be in the hippocampal area, and we've had other CTs on this stuff. The hippocampal area is associated with stress, memory, and executive functioning. And the study found that bully teens, I know this is stepping on some of the neuropsych stuff, but the bully teens perform more poorly on memory tests designed to examine that area than the non-bullied peers. To me, it's fascinating to see the pervasive effects of the bullying due to biochemical changes. Another point worth mentioning is that from the research, the victims of bullying experience not only heightened stress and immune responses, but I think you said before, someone over there, that they become bullies more themselves. They become more aggressive and become the victimizer. Now, why are they having this cycle of changing? So where is the chemistry thing going on? They showed higher levels of serotonin and lower levels of vasopressin. And when I first heard that, that confused me. I'm thinking, well, they're having higher serotonin, which we always want that, right? We give antidepressants to bump up serotonin. But it turned out that that was early on in the bullying phase. And what happened was, because their serotonin was higher, they lost their aggression. The vasopressin to serotonin level is aggression versus passivity. So with the serotonin going up, they just became passive and hopeless. They just let it go. They just allowed themselves to be beat. They didn't fight. They would just cower in the corner of the cage. So it wasn't a good thing that the serotonin level was going up. The hamster was too passive and did not protect themselves. So again, the reason this is important, some people think bullying toughens you up, right? Hazing in college, military type of hazing. And it's sad to say that in parents, I've had parents that will say, oh, little Johnny's got to toughen up. They got to take it. But it's really not the fact. It's more of a mental health crisis and future health, psychiatrically, medical health. You mentioned the somatic part, and it can't be tolerated. And the reason I brought this up in this talk was I just thought now they really have some very clear areas of the brain where you see structure and chemical changes when somebody gets bullied.
And so I'm going to focus a little bit on the psychosocial aspects of bullying. And what's interesting is the stress effect on the brain is particularly strong if the bullying occurs during adolescence, and it's even more pronounced if it's combined with a history of early life adversity. And, I just want to take you back to Adam again. And if you think about his situation, here he was exposed to that terbutaline in utero. He had the autism, he was inconsolable as an infant. They were already, the stage was kind of set for some difficulties that way. And then on top of it, and perhaps, as we'll see, even because of it, he ends up being bullied. And that combination is, especially difficult and impacts the brain. Second point, social pain, which describes feelings of pain that follow the experiences of peer rejection, ostracism, or loss. It's interesting that it actually activates a similar brain region as does physical pain. So that's something important to think about because, as Dr. Ken spoke about in his part about the bullying, it really is brain-based. So it's not something where you just sort of outgrow it, and I'll talk a little bit about that when I get to the long-term effects. There's a large body of research that shows that individuals who are bullied are at increased risk of psychological, emotional, and behavioral problems, especially internalizing problems. So things like depression, anxiety, being lonely. And it's interesting that often it seems that some people that are bullied may have some of those difficulties to begin with. So they're the people that tend to be maybe a little more lonely and kind of keep to themselves, and they're a little more in their heads, that they're a little more susceptible. And although Adam, we saw that certainly he had some externalizing behaviors, the aggression and so forth, and from an early age, he also had that piece where he was a little more ruminative. And if you think about even just the fact with those thoughts running through his head, that often he's kind of stuck in his head. And so it seems those people are more susceptible perhaps to being bullied. And then once you're bullied, then all the more you develop those internalizing problems. In terms of the short-term effects of bullying, you see social isolation, low self-esteem, feelings of shame, anxiety and depression, as we said, sleep disturbances, changes in appetite, bedwetting, higher risk of illness, and headaches and somatization. And indeed, if we look at this, Adam actually does display quite a few of these. And there is, of course, the interaction with autism in terms of social isolation and some of the other issues that I'm going to talk about that on the next slide. He did experience headaches. The somatization, as I mentioned earlier, was something that was identified and being targeted in high school after he left the residential treatment center where the bullying took place. So he certainly showed those short-term effects. And in terms of the long-term psychological effects, it's really important to point out that psychological damage doesn't go away because a person grew up and is no longer bullied. And it's really something that does stay with them. I have to say I've treated neurotypical people that have been bullied, and even there, it's something that years later as adults that they're still speaking about and still has an impact. So those kids who have been victims only, and there can be differences if you've been a victim or if you also were a perpetrator, so to speak. But those who were victims only had a greater risk for depressive disorders, anxiety, generalized anxiety, panic, and agoraphobia as adults. And a longitudinal study by a group of scientists in Norway found that victims showed a high level of depressive symptoms and an increased risk of psychiatric hospitalizations in adulthood. So certainly you can see that for Adam, that is, it has been true for him. And a really interesting study, it was a longitudinal study done where it reported that the effects of childhood bullying on adult mental health were stronger in magnitude than the effect of being maltreated by a caregiver. And that really struck me. So children who were bullied were more likely than maltreated children to be anxious, depressed, and to engage in self-harming behavior in adulthood. So, it really does have a tremendous impact. Just another point, research suggests that around the time of adolescence, it's actually more difficult to decrease emotionally aversive memories, such as experiences of having been bullied, than at other times in the life cycle. So that's interesting too, that as an adolescent, which often is when this occurs, that, here it is that there's probably something going on chemically, I would guess, in the hippocampus where, it's harder to suppress those memories. And so it sticks with you. And then we see that it has this tremendous impact long-term. And so the next slide focuses on bullying and autism spectrum disorder. While the CDC says that about 20% of individuals in middle schools report being bullied, it's actually much higher in individuals with autism. It's 44%. So they do seem to be at increased risk, probably due to the nature of their disability. So as it says there, the deficits in communication, the stereotyped behavior and interests, problems with developing friendships, limited social skills. And as I said earlier, that idea of the internalizing that way kind of sets them up for, being the ones that are targeted. As you can see, the one study found that it was the internalizing, not externalizing, that was a significant predictor of victimization in youth with autism. And so, and I've said it many times over, but that it puts them at risk for being bullied and then ends up leading to increased levels of the internalizing symptoms. And in another study, there was a negative relationship between being bullied and the youth's social skills. So again, if you have better social skills, that seems to protect you and you're less likely, to be bullied. And again, increased internalizing and externalizing problems, decreased social skills, and more conflict in friendships, which, as you can imagine, that is what we see in individuals with autism, that's associated with more bullying. And that was based on both youth and mother reports. So there does seem to be that for this population, they're at an increased risk. And indeed, that was the case for Adam at the residential treatment center, where not necessarily everybody there, did have autism. And so here we are, back to the future. We started off today really speaking about the idea that, Adam was referred for aggression and to control wrongful behavior. And I think, we've kind of exemplified by going through the biopsychosocial conceptualization that really, his situation is much more complex than that. And so why do we care? What's the purpose? Can we change his genetic mutation, the fact that he was exposed to butylene in utero? No, we can't. But I think if we understand him differently, then it may lead to improved opportunities, treatment interventions, and so forth. So let's talk a little bit about that. So, in terms of service opportunities, when we first saw Adam, he couldn't get into a day program. The crisis respite, he had been suspended from that. He couldn't participate. And now we're starting to see that as we've been able to reframe and understand him a little bit differently, the therapeutic coaching that's started to work on some of those relationships and how the family interacts, and maybe to turn some of that dynamic around that was started way back when, that as a result, he's experiencing his father differently. So now that affects how he is. And so we're starting to see that that's changing things. And we've been able to really reframe how he's viewed. And as a result, he's at his day program. And he's doing well, enjoying the basketball. So, again, if we just focused on the aggression, we might still be stuck there, and maybe he wouldn't have those opportunities. As I already touched on, in terms of the system and the family dynamics, by understanding those better, we could look and say, well, why can't this mother let go? We have no idea what that was about, or how come the father is so distant that way? How come he doesn't seem to care? But I think when we start to see, what had happened and how that triangulation started very early on, again, it gives us those clues. And with the coaching, we were able to go in and to kind of understand it a little bit better and to begin to help the family to turn that around. If we didn't know what was going on there and didn't understand the basis for it, then maybe we wouldn't have been able to do that. So that's important. And again, we're already seeing the benefits. In terms of specialized treatment interventions. So, when we were looking at Adam as this aggressive person and we didn't understand the bullying and how that's stuck with him, then we weren't able to identify, that degree of trauma. In addition to being separated from his family, that also, had an impact on him for sure. So, now understanding that, we've been able to try to connect him, although I think that's still a work in progress. He's not so sure he wants to participate, but to try to connect him with a therapist who's familiar with trauma-informed care. And even if we can't quite do that, then we can weave that into, helping the family to create that environment, the coaching. So other opportunities for that. In addition to, we've also made the referral for a sex education therapist since, as I said, perhaps because of that early dynamic of trying to console him, maybe certain boundaries were crossed during sexual development and, things got a little wonky and leading to some of the sexualized behavior. And so, trying to address that. Again, if we hadn't understood that the way we do now, then we wouldn't have been able to recommend those kinds of specialized interventions. And finally, PERMA, more of a positive psychology. We went from looking at Adam with respect to wrongful behavior, he has bad behavior, maybe even that he's a bad person, to, understanding him in a different light, where perhaps now, instead of wrongful behavior, we actually have empathy for him. And if we can help everybody in his system to understand that and appreciate that and to have that empathy, then I think we can help him to live a more enriched life. Even his understanding of, in terms of PERMA relationships. So he's like dead set. I think that was one of the first things, one of our first crisis calls was that he was upset and frustrated because his mother wouldn't give him additional funds so he could boost up his dating app and have more connections. And so you see that there, in addition to, as Jessica said, so desperately wanting to be normal and have a relationship and get married, they're also, now we can understand it from the perspective of the bullying, where he was always ostracized and left out, that all the more that he wants to have that and feel like everybody else and to be included. And hopefully, again, by reframing and switching how he's viewed, that it gives you a different understanding of what he's looking for there, and hopefully to be able to connect him to some social groups, which again, I think, he's making his way with the basketball and his opportunities at program, and maybe that will lead to other opportunities. So you can see that by looking at him differently, seeing him differently, and taking that time, with the biopsychosocial conceptualization, it has opened, more doors, more opportunities for him so that he can live a more enriched life. And Dr. Kent's going to kind of round it out with some of the more the medical, diagnostically, medication-wise.
Yeah, I just think it's important that we reevaluate diagnostically. Everybody knows the famous paper trail. Someone gets a diagnosis in 1995, another one in 1999, 2005, and then it just adds on and they don't lose them. So we have all these diagnoses, we don't know the accuracy. And as a child and adolescent, trained psychiatrist changes the rule, so you don't want to get locked into something like that. But you don't want to arrogantly Monday morning quarterback and say, oh, that's a joke, they were wrong, what were they thinking? Because maybe at that time it fit. They may have looked and appeared differently at that time than they do now. So the way I look at it is you want to look at the individual, how are they functioning today? What is how are they presenting with symptom-wise? And what are the possible variables that can explain it, and can they explain it better than some of those old diagnoses they used to have? In this case, psychosis was diagnosed early on, and I'm fairly sure it probably looked that way. You mentioned the little knife family running around. You know, it's not exactly like, this was like in the Yu-Gi-Oh, not Yu-Gi-Oh, the Pokemon. The little Pokemon. The knife sounds a little bit more dangerous, sounds a little bit more psychotic. But again, could this have been anxiety, an OCD person, and it comes across looking that way and describing it that way? And the way this individual was able to say that they get a loop in their brain, where it just goes over and over again and they can't get off that hamster wheel, that might have been misperceived as hallucinations. And again, I mentioned that when we first started, some people will split off those types of things from themselves in a protective way because they're embarrassed. They don't want to think that their brain is coming up with these kind of things. Because again, in OCD, it's very sexual, it's very violent, it's very, very forbidden. So a lot of times it'll be presented in a way that makes it sound like it's a command voice or something like that. It's more comfortable. Now, looking at the medications, those need to be reassessed all the time. Now, if someone has anxiety and OCD symptoms, and that's what's prominent right now when we're seeing them, maybe the antipsychotics aren't needed because a lot of times we get them on a ton of antipsychotics and there's a lot of side effects. Antipsychotics can work, but I used the expression before, a bit of a shotgun approach to maybe calming them down so they're going to look better. And I think in the beginning, someone said in this case, right, when they removed them, they may have gotten worse. And I always find it funny when a doctor removes an antipsychotic or medication and the person gets worse and they say, aha, you see, that was a diagnosis. Aha, you see, that was a needed. No, not necessarily. Personally, I wouldn't have removed it if they were doing great to begin with, but that's a whole other story. But if you removed it and there was a bit of a decompensation, before rotely going back to it, maybe there's alternatives. You know, maybe if it's PTSD, something that's affecting more the hyperarousal, like a guanfacine or an anxiolytic, if it's more anxiety. So I guess the main take home of that is when you remove medicines, look at it carefully and don't automatically go right back on what you're on, because it's not always an accurate conclusion. Last 2-second thing goes back to what you were saying about genetic testing. This case, it showed that he had complicated pharmacodynamics. No medications are going to work right. You sit down, like we were at that home visit. Oh, we tested it, nothing worse than my child. It says it on the gene testing. You really have to try to explain to the people. It doesn't work like that. It's not a panacea. I've seen plenty of people fail on a medication that the gene site testing says it's the perfect medication. And I've seen people bomb on that. And I've seen people do well on one that's very complicated. Because when they say it's complicated, what they're meaning is that the breakdown of it is complicated. So it may be that they're a slow metabolizer, which means you have to dose very low and go slowly. Or they may be a rapid metabolizer, which means you have to get it to a level and then maybe go a little beyond because they're chewing it up real fast. So take-home message on genetic testing on meds, not on the other stuff. It can be very helpful. It is a guide. It is not meant, this isn't going to be hopefully where AI takes over and people like me get fired, plug into the thing. This is what you're going to use. This is the dose you're going to use. It's still a bit of an art. And the genetic testing is helpful, but it is not exactly what you do, what you pick. It just shows you how to use it better. So I just want to throw that out. I get a lot of the consultations I get.
Yeah, thank you. That actually helps me out on a different case.
Okay, good. Yeah. Yeah, the last quick thing, I may have mentioned this story before. I had a pediatrician. I had this woman, she was a teenage kid, was so straightened out on medication. She was doing so wonderfully. Lexapro 15, whatever, doesn't matter. And they got rid of me. I understand that I don't take insurance, I'm expensive. They went to the other person, that's fine. And then I get a call back, you got to see her, she's a mess. I'm like, okay, bring her in, whatever, I'll deal with it. The doctor stopped the medication because gene testing said it was complicated and shouldn't be used. So I called him up and said, what were you thinking? He said, well, the gene test, I didn't know, but it was working. Why mess it up if it was working? And I tried to teach the pediatrician a little bit about it. So that's just a simple example that it can guide you how to dose it, but not guide you on what 100% should or should not be used.
I have a question about, you said like when one of the rats were tested that it showed that They just had to go experience like 5 minutes of bullying over like 4 or 5 times.
Sessions, right?
And it caused a problem. Because what is it like for human beings? Or has that even been said?
I don't know that it's quantified, but I think of it in terms of when I used to work at Bethesda Naval Hospital in Walter Reed, we had soldiers that were shot at, injured, so their friends passed. And it was very rapid. It unfolded in 2 minutes. So they had a couple episodes where they would hit and they had permanent damage. So I'm assuming it's probably a similar thing structurally, depending on the intensity of the insult.
Okay.
That doesn't take much, yeah.
And for people who you can suffer some of the things related to the bullying, but not the others. So, I mean, you don't have to.
Oh, yeah, no, it's not a menu, you have to get every item on it, sure.
One from column A, one from column B, right?
I have a question about the mom. Has her health, I know she had breast cancer, was treated after Adam's birth. Has her health been stable since with breast cancer?
Yeah.
Is Adam aware of her medical issues when he was young?
I'm not sure.
Just because I wonder, being aware of, medical issues every time she has to go for mammography, every time she has any checkups, that continues her whole life, even if it's been, 20 years. So I'm wondering if that's leading to more anxiety around kind of her health and that attachment to her as well.
That certainly could be, and we continue to see that attachment, and they are very much.
Yeah, I wasn't sure if he knew, that she got sick when he was, in utero and what she went through afterwards. Obviously, he was very young. He wouldn't have experienced it outside of the psychosocial implications like Denise spoke about, but even just knowing about it and then the follow-up every year, I'm sure she gets her checkups, even though it's been, 20-something years. So that could still be building upon the attachment as well as the anxiety if he knows about her appointments.
Yeah, that's a great point. And I think those are the things that we're continuing to try to kind of uncover with this case. This is a case that we could probably put up the biopsychosocial conceptualization in another few months, and we may have some more aspects to it. So again, that's why it's so important just to think that way and to consider all those possibilities. But I think it does go back to some of the parents' shame just in not being able to, and I can imagine as a mother, not being able to comfort and soothe your child. And so I think that, prevents them from maybe being as forthcoming as they might. So hopefully, as you continue to, improve your rapport, develop that further, you'll learn more. Does anybody have any other comments or questions, or it was unfortunate that the system couldn't be here today?
Did we talk about natural supports for the mother, possibly in terms of just being, a parent of a child with special needs, but also being a survivor of cancer? I think that a lot of that, especially in that sensitive time around when he was baby and the treatment and stuff, and I just think could have been killed, could have been so I'm supposed to be able to console my child, but maybe she really wasn't just feeling well enough to be
I think that's another great point. I don't know if everybody heard that, but just in terms of some natural supports for the mother, just with respect to, those feelings of not having been able to care for him, and certainly the dynamic continues, so it may be something that is worth addressing. I know that one thing we've spoken about is, and I didn't mention it, but trying to connect the mother to support groups or with other parents of individuals with autism and so forth. Again, that's all in good time. I think it's a matter of timing with this family, but that hopefully that would be something where then maybe that could address some of that shame and not feeling so alone.
coordinate later on.
Anything else? Any other comments or questions?
I think educating the system and actually showing them that biopsychosocial map, whether it be the care manager or any of the info support or the psychiatrist even, could be really powerful in a case like this because it is so interconnected, and until START came involved, nobody was seeing it from those perspectives. So I think even using that as a tool to work with the system for even the parents, that could be really powerful because I think the biggest takeaway is, it's not just about aggression. It's not just about his behavior. There's so many more things that are, playing a role.
I think that's a great point. We talked about, maybe having a whiteboard and certainly this is a case, and since the system couldn't be certainly following up.
Does anyone on Zoom have a question?
Hello, does anybody on Zoom have any questions? Are you still out there? Maybe not.
Did many people that are watching via their computer can speak through the computer?
There's things.
We actually have to wrap up though, we have other meetings.
Okay.
Okay, before you please leave your evaluations as well as the DIF identified document, we're gonna need those.
And everybody did sign the sign-in sheet, right?
I did not.